that we're seeing plenty of here on the East Coast. So we just wanted to make sure that you're aware of the fact this is going on and maybe coming, unfortunately, to an area near you. This presentation has also contributed significantly from Guanhui Chen. He was actually our first HIDA NMI pharmacy intern who's contributed significant information about xylazine to this, and also Captain Jason Piotrowski from New Jersey State Police, looking at the incidence and prevalency data on the East Coast, in particular New Jersey, where I practice. Also, we've had significant other contributions from others. So if this presentation is something you find to be very valuable, there's a significant number of individuals who have contributed to it who are listed here. And also all the other pharmacy interns we've had through the HIDA NMI program with Ed Shamilia and Dale Quigley, who you've heard from today. These are actually other interns we've had to contribute significantly to this presentation. So objective is actually list and identify signs and symptoms of fentanyl and xylazine. We're going to describe the practical treatments for both the overdose and withdrawal. We're going to talk about the prevalency of this actually occurring both in New Jersey and the East Coast and also the United States, and actually some harm reduction strategies you may be able to implement in your area there in California. So this just shows you the numbers. It's been 96,000 drug deaths. It's now over 107,000 that we know with regards to what's occurred in our country, and unfortunately ever increasing. Xylazine has actually made these fentanyl and stimulant overdoses worse and more difficult to manage. And we're going to talk about that as to what's occurring and also how to manage them even in a better way. This shows you the overdose deaths driven by primarily opioids in black and obviously synthetic opioids with fentanyl in the gold color. As we're aware of, this has been a significant problem on the East Coast for quite some time. And now with our opiate supply and stimulant supply being cut with xylazine, it has made those overdoses more difficult to manage. There's been a recent alert as of March 20th of this year that was released by the DEA talking about the widespread threat of fentanyl mixed with xylazine. Here you can see it's highlighted in this slide with regards to the fact that the DEA has seized xylazine with fentanyl mixtures in 48 out of 50 states in the United States, and that 23% of fentanyl powder and 7% of the fentanyl pills that were seized by the DEA contain xylazine in them. We have a much greater amount of the presence of xylazine in our drug supply here with opiates and stimulants in New Jersey and on the East Coast, which we'll talk about. There's also been an alert from the FDA that occurred on November 8th that was actually to healthcare professionals, making sure that we are aware of the fact that the illicit drug supply is tainted with xylazine and is causing significant problems, that we should all be made aware of it, and then also seek information with regards to cocaine poison control or others on how to manage these more difficult cases if they should occur. This actually shows you the emergence of this adulterant. 25 states back reported about 67% were all occurring in the Northeast region. But this map shows you with regards to the prevalence having increased significantly in a short period of time. In January of 2019, only 8 states reported that there was xylazine in the drug supply. You can see as of June of 2021, that increased to only 12 states not reporting that xylazine was a drug supply. And as we just showed you, the DEA is reporting now that 48 out of 50 states have reported that xylazine has been in their drug supply. This shows you data significantly out of Philadelphia. The Kensington section of Philadelphia, unfortunately, is an epicenter for this problem. It shows you that in the unintentional heroin and fentanyl overdoses in Philadelphia from 2010 to 2015, only 2% had xylazine in them. You can see how that jumped from 2016 to 2019 on the left side of this table, going from 10 to 11% up to 31% in 2019. And it also shows you with regards to the demographics that the co-detection existed. 100% was in the fentanyl cases, 53% in cocaine, 28% in benzodiazepines, 10% of the heroin, and 7% of the opiate supply in the city of Philadelphia with their fentanyl overdose deaths that contain xylazine in them. So with regards to illicit use, this adulterant is being used to cut fentanyl, heroin, cocaine, and methamphetamine. And with regards to that, we know that methamphetamine is a significant issue on the West Coast in California, even more so than we see in New Jersey. Although this is changing across our country, we are seeing more methamphetamine in the East Coast, and you are seeing more opiates and fentanyl on the West Coast now. That's kind of shifting. And with regards to that, it's important to note that fentanyl and heroin and the stimulants, cocaine and methamphetamine, are all being cut with xylazine, and we'll talk about why that's happening. This is also being used to engage in drug-facilitated crimes, whether it be sexual assaults or robberies or those kind of things where they induce sleep on the victim. And then in the illicit drug supply, if xylazine is being used as a single agent, that is referred to as trank. When it's mixed with fentanyl or heroin, it's called trank dope, and other names include sleep cut, Philly dope, or zombie drug. So how did xylazine even come about and its purpose and usage? It was originally developed as potentially medication back in 1962 by the Bayer Pharmaceutical Company. It was being looked at to be analgesic for pain management. However, those clinical trials were stopped due to the fact that the medication caused severe hypotension, so low blood pressure, and also CNS depressant effects. But we did notice that xylazine was being used to cut the drug supply initially in Puerto Rico back in the early 2000s from the DEA detecting it and reporting it there. The medication, though, xylazine, is currently used still for veterinarian use only. It is a product that is used significantly by veterinarians. It is used for pain relief and also muscle relaxant properties when they do procedures on different animals, horses, deer, moose, elk, and different large animals. It is actually used to engage in diagnostic procedures or surgical ones, and the medication is used to relieve pain as it works as a local anesthetic. There are different brand names there you can see: Rompune, Cetazine, Anised, Xylamed, all of those. And what's important is that xylazine is not currently controlled under the Federal Controlled Substance Act. So it is not a controlled substance. It is controlled in the state of New York by Murphy's Law back in 2017 as a Schedule III substance, but that is the only state that we are currently aware of where xylazine is a controlled substance in the United States. This just shows you the pharmacology and also different brand names. I see pictures of those. These vials cost about $18. That's it with regards to being able to order it. It's why the FDA has cracked down on shipments to making sure that they're now going just to veterinarian practices and someone's just ordering it off the internet, having it sent to their home. But it shows you here that these pharmacokinetics amongst the animal species did not vary significantly. The onset of action is a few minutes, so it does work very quickly. It does last for about 4 hours in animals, and it shows you the commercial solutions here of 20 milligrams up to 300 milligrams per milliliter. And it's a significant with regards to those concentrations because only micrograms of this substance can cause problems in humans. So you can cut a lot of product with regards to using xylazine to cut illicit drug supply, and it doesn't take a lot of it to use that based on these concentrations that are listed here. For the pharmacology, it's not well established in its use in humans. As we told you, it does cause severe hypotension in clinical trials. It is mainly an alpha-2 receptor agonist. That means it's positive effects on the alpha-2 receptors, and they cause a decrease in the release of norepinephrine and dopamine in the central nervous system, and that's what results in the pain relief, the sedation, and the muscle relaxation. It can also, though, exert agonistic activities on these other receptors: cholinergic, serotonergic, dopaminergic, alpha-1 adrenergic, which is key because that causes some of the vasoconstrictive problems that xylazine causes, also histaminergic, and also opiate receptors. So there is a significant impact on multiple receptors by xylazine in the human body. It does actually potentiate and add on the sedative effects of fentanyl and heroin, so they kind of last longer. That's why there's an issue with it being used. For those individuals who are familiar with using heroin, that has a longer half-life. It would last longer, and fentanyl has a shorter half-life. It doesn't last as long, so people need to inject fentanyl more often. When xylazine is added to the mix, they do not have to do that, and that's one of the reasons why they engage in xylazine and fentanyl use. It does remind individuals, it makes them feel like they were on dope like heroin in the old days, and that it would actually last longer when fentanyl replaced heroin. And it does give them the nods with regards to that sedative effect when this happens. The other reason that xylazine is being used to cut the drug supply, in particular the stimulants like cocaine and methamphetamine, is because it balances the sympathomimetic effects of stimulants. And what are those? When someone uses cocaine or methamphetamine, they have an increase in their heart rate, tachycardia, or they become hypertensive, they have high blood pressure. Xylazine actually lowers your blood pressure and lowers your heart rate. So someone would still get the high and the stimulant effect from methamphetamine and cocaine, but not necessarily have significant increase in their heart rate or blood pressure. And that's why it's being used to decrease those situations with their heart rate and their blood pressure from happening. In particular, with regards to reported toxicities, there are lethal levels in humans. It's not established due to the overlap of fatal and non-fatal overdoses. It shows you here that the non-fatal level is anywhere from 30 to 4,600 micrograms per mil. So it's significant with regards to that range. And again, we showed you it's 20 milligrams to 300 milligrams per mil that come in these vials. Symptoms include blurred vision, disorientation. They will become drowsy, staggering around, zombie-like coma, bradycardia, low heart rate, depressed respiratory rate. They'll have a low blood pressure. Meiosis is the constricted pupils that you see with opiate overdoses, which is key because they will remain with shrunken pupils with meiosis if they are on a xylazine effect. It does cause ulceration of the skins and also potentially elevation of their blood sugar, the hyperglycemia. Again, the fatal level here it shows you is 16 milligrams per mil, and the smallest vial there was 20 milligrams per mil. So less than an ml of xylazine can actually be fatal to individuals, both as a contributory factor when it's added to other substances or in sole use when just tranq is used by itself as in xylazine alone. It is just transferred to a major metabolite, 2,6-dimethylanilene. And what's key here is a hydroxylated metabolite can be detected in human urine if an overdose does occur. Most hospitals don't test for this, but if an extra sample is saved, it could be sent out to determine if someone actually has overdosed on xylazine as part of the overdose of polypharmacy overdose that may occur. This just shows you some of the prevalence with regards to New Jersey. What's interesting here, we're looking at just fentanyl. On the left, it shows you in the first quarter of 2015 in New Jersey, these are complimentary from our New Jersey State Police and Captain Piotrowski, that when heroin submissions were sent into the New Jersey State Police Forensics Lab, 98% of them that were heroin tested positive for heroin. Now, in the fourth quarter of 2022, only 2% of our heroin submissions test positive for heroin. They mostly test positive for fentanyl. And that's truly showing that fentanyl is a huge presence in New Jersey in our drug supply and is significant with regards to there's really not much heroin at all by itself in our drug supply. This shows you the glassine bags are actually in red. 88% of them have fentanyl in them, and 97% of the submissions that were suspected for heroin have fentanyl in them. In the blue line here, this shows you that there are 21 counties in New Jersey. All of them, 21 counties, we average more than 97% of the submissions to be detected for heroin test positive for fentanyl, and some of the counties even have 100% of their submissions for the year. This is looking at the entire year of 2022 for their glassine bags or their submissions tested positive for fentanyl, showing the prevalence is significantly high in our drug supply in New Jersey. The other problem we have, though, is we have multiple, and I stress multiple, fentanyl analogs in the drug supply in New Jersey as well. So this shows you from 2013, when fentanyl first appeared in our drug supply, over 10 years now, that in 2021, we now have 40 different fentanyl analogs that have been in the drug supply in New Jersey. And that's important because some of these analogs are more potent than fentanyl, some are less potent than fentanyl, and not all of them will be detected on fentanyl strips. So with regards to its presence, not only do we have fentanyl, but we have 40 different analogs as well. So what about xylazine? Xylazine presence has increased dramatically. As you can see here in this graph, in 2021, we had over 240,000 glassine bags that actually tested positive for xylazine in our drug supply, and that was an increase of 694% from 2020. And you can see that initially we had xylazine in the drug supply in 2015 with 84 cases. When we got over 1,000, New Jersey State Police issued an alert in New Jersey back in 2016 and again in 2019. And of course has issued it every year now because our supply has been significantly tainted with xylazine in the mix, here showing the 240,000 samples in 2021. This also shows you with regards to submissions and the glassine bags that about 30% of our drug supply, 29% in both 2021 and 2022, even though the submissions have gone down, it's still averaging about 30% with regards to the presence of xylazine in any of our heroin samples that are sent in to be tested. This breaks it up by county. What's important here is the one that's highlighted most in red, the 979 total submissions and 17% of xylazine-related submissions in Camden County, New Jersey. That is the hospital where I work at, is in Camden County, New Jersey. We see this significantly with regards to coming into our hospital. We just had a significant case this past weekend that I worked where we actually had a gentleman who unfortunately is being treated for a MRSA infection of both his hands and both of his feet because of his stimulant injections that were actually cut with xylazine, and he's being treated for a severe infection and has the potential to actually lose both his hands and both his feet if this treatment does not go well with regards to the xylazine tainting of his methamphetamine drug supply that he was injecting. So significant cases that we see, unfortunately, way too often where I work in Camden County, New Jersey. This also shows you that the submissions can be significant, anywhere from 50,000 to 78,000, depending upon the county. So it is significant drug supply that is showing the presence of xylazine in the mix throughout our state. Our naloxone treatments have gone up, which is significant here, and that we're up 7% for this year. What's important there is that xylazine will not respond to a naloxone reversal. naloxone should be given for the opiate overdose component and should be given all the time, and we'll talk about that. But most importantly, it will not reverse xylazine if that's part of the mix. And you can see here our law enforcement is in red and our EMS is in blue with regards to the amount of naloxone administrations that have been given in New Jersey. And importantly here in Camden, as well, it shows you here that we're second highest with regards to naloxone administrations. We averaged 3 naloxone administrations per day, and in 2022, our highest was 13 in one day during the course of the year in 2022. So does this really happen in New Jersey and in California, in our neighborhood, in your neighborhood? If you haven't seen the presence of xylazine yet in your area of Sacramento, you may soon, because of the fact of how rapidly this is spreading across the country. And there's a reason for it, because they can actually lose less fentanyl if xylazine is actually in the mix of the drug supply. So these are just samples of what we have actually seen in New Jersey to show you the stamps with regards to Adidas and its pink powder. Sometimes very much looks powdery, sometimes look more like a rock in the middle one here. The stamps that are on there with regards to that, it's a blue powder, pink powder, that can vary with regards to its color. The other one to be aware of is that we're seeing these pink flip top vials. I don't know if that's in the drug supply out in California, in particular Sacramento area, but this is a new thing here. We used to have glassine bags for the most part that were stamped. Now they're using these pink flip top vials, or clear ones or blue ones that mark what drug supply it is, depending upon the substance and what they're actually pushing out there. You can also see the yellow rock colored formations here in the bottom of even a brown, dark brown substance. But notice all of these had xylazine in them, but also mixed with different substances. So fentanyl, cocaine, fluorofentanyl, tramadol, and different substances, 4-APP, which is a fentanyl precursor, all those in the mix for drug supply. This is important with regards to xylazine-related deaths. So as I mentioned, in Camden County, New Jersey, where I work, you can see that 51 of the deaths we had in Camden County, which were over 355 for the year, 51 of those were actually xylazine-related deaths. And for 2021 and 2022, Camden County, New Jersey has had the highest number of xylazine-related deaths in the drug supply across the state, but we have seen it in all of the counties across New Jersey. This is actually out of the city of Philadelphia, showing you purity. This is important because the average fentanyl purity is in blue and the xylazine purity is in yellow. And why this is important is because it shows you that in both the second quarter and fourth quarter of 2022 in the Philadelphia drug supply, the difference between the purity of xylazine and fentanyl was statistically significant. And as the xylazine purity has gone up, the need for the purity of fentanyl has gone down, giving them more fentanyl to be able to use in the drug supply and have more samples to be able to sell if they're cutting it with xylazine. So there's an issue with regards to xylazine making the fentanyl last longer from a high perspective. It also is with regards to the purity of the fentanyl doesn't need to be as high, and they would have more fentanyl to be actually able to use and sell in multiple doses with mixing it with xylazine, accounting for its popularity, unfortunately. So this actually shows you other ones. If you're familiar with the East Coast, Atlantic City, New Jersey, these are just ones that are highlighted in the red boxes showing heroin, fentanyl, and xylazine and others. But the one that's actually highlighted in there in yellow is actually showing you a overdose that actually contained 10 different drugs with regards to this. And it's pretty rare that we see, as you can see with xylazine in the mix, that it's by itself, and even just with fentanyl. There's usually other components to this. And this one in particular had fluorofentanyl, fentanyl 4-MPP, cocaine, clonidine, diphenhydramine, phenylethyl 4-MPP, xylazine, heroin, and 6-MAM, which is actually the metabolite of heroin. So it's significant with regards to how many substances were involved in this particular overdose of this one patient. Also, cocaine and diphenhydramine and xylazine. Again, you can see no fentanyl in the mix there. Again, with xylazine being used to cut the cocaine supply is one of the other examples there with xylazine in the mix, and the other two samples that are in the red box. So what about xylazine skin necrosis? And we're going to give you kind of a public service announcement. There are significant pictures coming up with regards to showing these necroses that occur. They are significant with regards to this, and they also are significant with regards to the infection that can develop. The issue is that it is heavily reported with xylazine injection, the skin necrosis. It occurs because of low skin oxygenation to these tissues, especially where they inject, and also because of the fact that we mentioned that xylazine is also an alpha-1 receptor agonist, and alpha-1 causes vasoconstriction. So when you decrease the blood supply to these areas, and then also decrease the amount of oxygen being delivered there, those tissues where injection sites occur frequently develop infections, and then those infections can lead to significant necrosis that can lead to, unfortunately, potentially even losing their hands, feet, fingers, limbs, those kind of things. The skin ulcers are painful, and they could occur also at a non-injection sites. That's important. So areas where they don't have much blood flow to begin with, peripherally, fingers and toes, their gluteus, if they're sitting on their buttocks, because of the fact that they're very stationary, zombie-like, they get less blood flow there. Now they have decreased oxygenation and also are using Xylazine and not injecting in their buttocks. But the thing is, they do develop sores or wounds there. That does happen, and they will re-inject into the areas where they are developing sores because, as we mentioned, being alpha-2 agonist, it does decrease pain. It's used for analgesia. So they will actually repeatedly inject in the same site, and that increases the chance for the skin necrosis to develop. The abscess formation worsens with necrosis, and the wound healing, because of lack of drug supply and oxygenation, is significant. So these wounds are very difficult to heal once they get them. And many of those, as we have witnessed, require surgical debridement and skin grafting to fix those when they occur. This is actually a patient that we had with regards to fentanyl, cocaine, and xylazine. We're showing you the x-ray first because you can see here that's important is the fact that you can see here how dark it is on this particular portion of the x-ray. And this is truly where the skin has been eaten away by the infection. We will do this repeatedly on these patients because what we're looking for is to see how deep this infection got to, because we're concerned about the fact that they may infect their bone, in this case, the gentleman's arm. And he came into the hospital saying he did not want to lose his arm as to why he was showing up. Fortunately, he did not have the bone infection, osteomyelitis, but he did have a wound that looked like that. And what's significantly is we use broad spectrum antibiotics, pip/tazo, which is Zosyn, piperacillin, tazobactam, and also vancomycin to treat those infections to minimize the fact that we can kill off as many potential infective agents as they are until we get a culture back. And then we will specifically target certain antibiotics if we can stop the vanco and pip/tazo, although vancomycin usually stays on board with these type of infections because it involves MRSA as a type of infection. This shows you some xylazine skin necrosis cases that were from Puerto Rico, showing they notoriously will inject into the shin and or the front portion or the calf of their legs. And also the one in the middle there shows you he would inject actually into his thigh. So they're looking for those types of injection sites, and will also do it repeatedly into their forearm. This shows you, unfortunately, a right lower leg in the top and a left lower leg with regards to the severity of the skin necrosis that occurred in this particular patient. And this one actually shows from a patient in Philadelphia where they didn't have the leg skin ulcers and cellulitis, but this person also had the osteomyelitis, did have the bone infections bilaterally of both of their legs from how severe the necrosis was, and then how deep the infection was to actually down to their bone and cause a bone infection in both extremities. And this does have the potential to cause significantly the risk for amputation of these limbs if we cannot control the infection, because it could spread and then also to other parts of the body, including their heart, and also lead, unfortunately, to their death. So this actually looks just one of our cases that we've actually had. This was a significant case that was with Guanhui Chen, Dr. Guanhui Chen, who contributed significantly to the presentation with regards to this. There was a 30-year-old woman who came in. She had a past medical history of depression, endocarditis, so she had her heart infected before. She actually came in because she had been repeatedly injecting fentanyl and ketamine into her neck. That's how severe her infection was, and also her drug habit. She was up to 30 bundles, it says, so it was 30 bags of fentanyl a day on her own, and she was trying to taper off of that on her own. That was causing her to go through the significant withdrawal syndrome and also to overdose when she used. She presented to the emergency room after 3 days being out in the field, reported vomiting over 20 times. She was very agitated. She had hypoxia, so she had a significant decrease in oxygenation. She was in shock, cardiogenic shock in particular, with her heart not pumping significantly. And she was very cold with regards to her extremities. Anything in red here that shows you on this slide are things that were abnormal. Her temperature was 103, so she was at a significant fever from the infections. She also had a heart rate in the 180s, so she was actually in paroxysmal supraventricular tachycardia, very high heart rate with regards to this. She had a high WUD count, 21. She had infections. Her potassium, magnesium were low. Her K and Mg, they're listed there. BUN and serum creatinine were elevated. That means she was an acute kidney injury and failure. Her liver function tests were elevated. Her troponin peak there at the bottom there in red of 14,000 showed that she had also had a heart attack, and her BNP being over 35,000 shows that she was also in heart failure. So the EKG showed that she actually had premature contraction. She had non-specific T wave changes, indicating she had an MI. Her QTC was also prolongated. We did do a stress cardiomyopathy test on her and showed that was positive. So she actually had Taksubo actually induced cardiomyopathy from the stress that she was having with regards to that. And that had her ejection fraction down for her heart down to 10 to 15%. Anything below ejection fraction of 40% is considered to be heart failure. And she definitively had that at the highest stage of 10 to 15%. Every time her heart would beat, it would only eject 10% of the blood in there, which is significant with regards to the heart failure. She had severe edema, so she had all the swelling with regards to that, and also had possible pneumonia, which was probably from aspiration pneumonia when she actually got sick and all the vomiting that was occurring. And she was positive for hepatitis C there, as you can see, but not positive for hepatitis B or hepatitis A. To treat her, she had acute hypoxic respiratory failure, so she needed to be intubated. She was sedated with fentanyl and midazolam. She was put on propofol to sedate her and keep her sedated. Furosemide, which is Lasix, is a diuretic that was given for pulmonary edema to get the fluid out of her lungs, because that was also contributing to her significantly to her critical care situation. Unfortunately, with the supraventricular tachycardia, that heart rate that was in 180, she required adenosine and also cardioversion that did not work in the emergency room, and she had to be put on amiodarone on day 3 to control that. But she was in such severe cardiogenic shock that she had to have an implant placed into her heart that would increase the ejection fraction for her mechanically. As you can see there, it looks like a little bit of a fish hook in that left chamber of the heart to actually help with regards to increase her ejection fraction each time it would beat. We also gave her milrinone that helps the heart when each time it beats push more blood out of there, and norepinephrine to raise her blood pressure. And we talked about the antibiotics she was on initially as well, into also going into acute kidney injury there. So for management, we had to replenish both her low potassium and her low magnesium. That's because of the fact that they contribute significantly to cardiac arrhythmias if they're too low. So we had to raise those as well. We gave her a heparin infusion so that she would not develop any type of deep vein thrombosis or pulmonary emboli. She was given pantoprazole because of the ulcerative effect potential in her stomach from just being in the intensive care unit, evaluated for alcohol and opiate withdrawal. And she was also sedated on other medications and treated in the intensive care unit to get her through this particular event. We did get a palliative care consult, and the concern here was because of the fact that she was withdrawing significantly because of the fact of using 30 bags of fentanyl a day, and it was presumed to be laced with Xylazine because of the neighborhood she had come in from Philadelphia, the Kensington area, which we know is notorious for this. And fortunately, when getting a site consult, they came through and saw her, and that they identified readily that she was actually also going through Xylazine withdrawal. And there was concerns because of the fact that when we started the methadone for medication-assisted therapy to keep her from having significant withdrawal from the opiates, she was then placed on that, and it wasn't working entirely, and wondering why she was still exhibiting signs of withdrawal. They were able to identify the fact that if this was truly a Xylazine component to this, and the symptoms she was presenting with indicated that she should be treated for both a Xylazine use disorder and withdrawal, along with the methadone for controlling the opiate withdrawal. And that's exactly what would transpire with her. So what we were able to do is that we also put her on alprazolam. The problem is people have significant delirium with regards to this, and she was also unfortunately abusing benzodiazepines. We put her on dexmedetomidine, which is Precedex, which was an alpha agonist that was highly suggested to use because it would actually replace the Xylazine. The only problem with that is that dexmedetomidine causes a decrease in her ejection fraction and her heart rate and her blood pressure. And that was a concern because we were trying to get her out of cardiogenic shock. Clonidine is actually also used along with guaifenesin or tizanidine to treat the Xylazine withdrawal. And what's important there is that clonidine is also a major alpha-2 agonist and would decrease the blood pressure. So that was one that we couldn't use. And also there was a blood pressure issue with guaifenesin. So we had to defer to the third option, tizanidine at 18 milligrams a day to treat the Xylazine withdrawal symptoms she was experiencing, along with the methadone to treat the opiate withdrawal. So she was hospitalized on this, getting the fentanyl and midazolam, methadone as well. We added the tizanidine to 2 milligrams 3 times a day. That was increased. The key here, though, with this is what has to be remembered is that, unfortunately, tizanidine is also a QTC prolongator. So when your heart beats, lub-dub, 1 beat, you have a P wave that tells your heart to beat, a T wave at the end that tells it to pause before the next heartbeat. And if that elongates, the P wave will overlap the T wave. And when that does, people will go into sudden cardiac arrest because their heart will stop and go into asystole and stop totally. So we have to measure the QTC all the time. And anytime it's over 500 milliseconds, we worry about it. So she was prolonging this from the methadone, also the Zofran for the nausea vomiting treatment, and now also tizanidine. So we're able to monitor that. We also determined she was able to switch out to ampicillin and sulbactam unison to treat her pneumonia, aspiration pneumonia, and that the vancomycin and the Tazo was not needed as much anymore. Also, the methadone was discontinued because now that QTC prolongation did get above 500. We had to switch to olanzapine to calm her down. And also, again, we showed you keeping the potassium and magnesium above 4 and 2. She was able to be extubated on day 5, fortunately, and we were then able to slowly taper the fentanyl and midazolam to treat her. And the impellet implant was removed because now her ejection fraction was up to over 50%, and she was alert and oriented. So she did recover from this event and was managed accordingly. And then because her QTC was below 500 at 488, we were able to reintroduce the tizanidine to treat her. These are the drugs that she was on when she was discharged on day 23. The gabapentin was used also to help in detoxification. The alprazolam was tapered off for discharge. She was put on tizanidine to treat, again, the xylazine withdrawal that could continue as an outpatient, and also the methadone to treat the opiate withdrawal. And she was obviously given naloxone in case she should decide to use again to be able to have that reverse right away. And metoprolol is a drug for heart failure. She was placed on that, obviously having demonstrated she had that occur, and also the fact that she had a troponin spill, which means she definitely had a heart attack as well. So she was given that for the cardiac benefits of metoprolol. So with regards, it's important with regards to, based on practicing the withdrawal, is that dexmedetomidine is the first choice. But again, if they present with this cardiogenic shock like she did, some patients will not, then obviously dexmedetomidine and clonidine would be the preferred agents. And it gives you there in red the maximum doses for each of those per day at 1.5 for the clonidine, 9 for the guanfacine, and 18 for withdrawal for tizanidine, although for other indications, it can go up to 24 milligrams. So here's what's important with regards to xylazine treatment and summary. Notice the toxidrome that's listed here, the concentric circles in the top right. This mimics an opiate overdose. So this is important because opiate overdoses or xylazine overdoses, or when they're combined together, will cause CNS depression. They will cause respiratory depression, a low respiratory rate. They will cause bradycardia, a low heart rate, hypotension. They will cause low blood pressure, meiosis. The pupils will be shrunk, whether it be from the opiate component, the xylazine component, or both. And that's important because if someone is reversed with naloxone for the opiate component, you would think that those pupils should get back to a normal size or actually dilate when the meiosis is reversed with naloxone being on board. But that will not happen if xylazine is a mix, because xylazine will keep the meiosis occurring. What's most important here is airway protection all the time for these people. That's why she was intubated. Again, for sedation, the Precedex is preferred, the dexmedetomidine. We give her IV fluid and vasopressors to raise that blood pressure because of that. She was treated with electrolyte imbalance, and also the skin necrosis was treated with the antibiotics that we talked about. The key here for supportive care is that xylazine is not an opiate, but xylazine should always be administered. That's to rule it an opiate component or to totally block the opiate component that will occur. A higher dose of naloxone and higher dose of naloxone-induced non-cardiogenic pulmonary edema may occur, and this is a big issue for us in the hospital for people to be aware of. If you give enough naloxone, sometimes people will have fluid go into their lungs. It's similar to a dry drowning. Someone who swims in the ocean, unfortunately takes on water, they don't drown, they may aspirate some of that salt water into their lungs. They have the potential to go home and actually fall asleep. And when they do, they start pulling fluid into their lungs because of the salt water in their lungs. It's similar in that naloxone may have them start pulling fluid into their lung tissue and into their lungs and then start to fill up with fluid. It's why anyone who is reversed with naloxone should always go to the hospital to make sure there's no recycling of a long-acting opiate if they took it, and or if xylazine is a mix, to make sure that they actually don't have a problem later on with regards to pulmonary edema, that if we needed to, we can emergency intubate this person and have them survive. What's key here is that there was one study published looking at proposed reasonable ranges of 4 to 6 milligrams of naloxone intramuscularly, or 8 to 12 if given intranasally, and that people should actually use it until the person responds. But if they do, and now they've responded totally, but they're not totally out of the overdose, to truly suspect that xylazine may be on board in the mixture. And we've seen this significantly, unfortunately, in our area. So recommendations for clinicians is to be aware that the illicit drugs that contain toxic adulterating substances may complicate the clinical presentation as demonstrated by this particular case, and that we see, unfortunately, with xylazine in the mix. To become familiar with those signs and symptoms, so that toxidrome summarizes tremendously what the associated xylazine toxicities are that occur. To be aware that the routine hospital drug tests will not disclose the presence of xylazine, and you may require special tests for that. So that's important. Medical examiners for tests for common adulterating agents, suspected stimulant and or opiate-related deaths that may occur, and that's because of the presence of xylazine. And like we mentioned, xylazine may be present in opiates, fentanyl, heroin, may be present in cocaine and methamphetamine, other stimulants. To look for those if they think that the overdose was extremely complicated to manage and the death. Forensics and clinical laboratories should include xylazine in their scope of testing. Our forensics labs in New Jersey test for xylazine all the time now. To develop a sensitive confirmatory procedure about common adulterating agents like xylazine, if there's something else that's suspected, some type of new novel psychoactive substance occurring. We have, and I don't know if this has hit California yet, but we have isonitazine in the mix in our drug supply. This is 3 times more potent than fentanyl. There are 7 analogs of isonitazine as well. It's named ISO that may also occur. So that's now being tested in our drug supply because we have had outbreaks of that, protonitazine and metonitazine in particular in New Jersey. So that has happened. Consider lab analysis for drug samples taken from overdoses and investigations. We have a closed loop where if they test positive in the medical examiner's office, we also look at the drug supply. If there was some seized from the scene, to close the loop that the person did truly take that and xylazine was in the mix, not only the paraphernalia that was present, but also in their system if they have an evaluation by the medical examiner. And to share that data for seizures in your jurisdiction with medical examiners, coroners, and police law enforcement departments, along with health departments, to know that that's out there and that they may have to engage in significant naloxone deployment and have the person come to the hospital. So recommendations, if you increase in xylazine cases are suspected, contact your state and local partners for appropriate community response. If you start to see this in your situation, raise awareness among drug users to be aware that they have the potential to have xylazine in the mix and that that cause significant complications if they should overdose. And they should call 911. Naloxone should be administered again, and to share that information with the State Department of Health. And we've had this where, depending upon how complicated the presentation is of the patient, we have had to call New Jersey Poison Control significantly with regards to that. And this slide content here gives you a PDF you can go to with regards to a health advisory specifically on xylazine. That's listed here at the bottom of the slide for those recommendations. Also, with regards to public health initiatives, New Jersey State Police, our Drug Monitoring Initiative and Analysis, has a health prevention sharing network and a fusion center partners. We have calls once a month with regards to both of those groups that we participate in regularly with Captain Piotrowski and others. These calls are then also translated to other documents and alerts that are sent out to us. And we follow OD map and also OD form, where depending upon the overdose, significant information is captured above and beyond that. And we just contacted the captain this morning because we had a huge outbreak in South Jersey this past weekend when I worked, asking if he definitively had seen a spike in South Jersey, and they did in other counties surrounding ours. So it was definitive that that did occur over the weekend. But that's the kind of communication we have here on the East Coast with our law enforcement and medical colleagues. We also have the Camden County, New Jersey Addiction Awareness Task Force. We have started a huge thing with regards to addressing xylazine in our county. There's also Ocean County has an overdose fatality review team. They look at all of the overdoses in particular to see what's in the mix and how they can address that with regards to how they've occurred. This also occurs in Delaware with the Substance Abuse Epidemiological Outcomes Working Group. There's a Central Virginia Overdose Working Group that both Captain Piotrowski and I serve on, with helping them out with their situations they're dealing with in Virginia. And then also, if you have any requests, Dale and Ed are very familiar with our High to NMI Pharmacy Intern Program. If you have information you're trying to find, you can easily reach out to us through High to NMI, and we can have our interns go look up this information for you and get it back to you. And that's been really beneficial for people all across the country asking different questions for us, and in particular from our pharmacy interns. Some of the other ideas are to save additional 10 to 15 mLs of a urine sample for novel psychoactive drug testing. Again, if you're trying to find out what did occur specifically, and in particular of those things that occur, can you test for them and identify even a novel substance that may not be xylazine, but something brand new in the drug supply? The other thing is, California considers scheduling xylazine as a C3 category by state, as New York State has done. We're under the initiative of doing that here in New Jersey, having conversation with the Attorney General's office, with different medical personnel and our law enforcement to encourage them to do so. We will tell you to be aware that you may get significant pushback from the horse racing industry, because they obviously use xylazine a lot to treat their horses, and they need to have this medication readily available. It would put restrictions on that with regards to ordering it and how you document using it and how you document the waste, which is key for diversion, but it would not eliminate them from being able to get it. So there would be some things with regards to extra documentation, but they could still use the product. Obviously, naloxone prescription should be given out with any kind of pain prescription. That's been advocated from our Rowan School of Osteopathic Medicine, where we're adjunct faculty there, from our pain management physician, who's now our acting dean. Anytime someone receives a pain management prescription with an opiate, they should receive a prescription for naloxone at that same time. The FDA is fortunately considering over-the-counter naloxone, that people could just go in and get that as an over-the-counter medication. Again, the key there is, our concern as a healthcare professional is the flashback pulmonary edema that may occur. And so anyone who is reversed should go to the hospital to make sure they are stable before they are sent home to then fully recover from the overdose. We also have implemented in Philadelphia, in the Kensington area and others, and also in Camden County, in our major area of Camden City. We have mobile vans that go out with nurses and actually treat these xylazine patients for the wounds that they have and give them care for them, and also to hopefully minimize or decrease the potential to become infected, and also offer substance use disorder treatment for anything that they may be struggling with. We also have these law enforcement and healthcare professional consult and communication teams set up. Again, with the New Jersey State Police, it's not uncommon for me to talk to Captain Piotrowski once a week, and we already did so today, and probably will more so during the week based on what has transpired recently in our areas. And also we have put recovery coaches in the emergency departments in our hospitals and also inpatient hospital to encourage people for their substance use disorder to get into treatment and get the help that they need so they can hopefully go into recovery. So wound care, if someone is unable to regularly assess hand washing, we actually offer this through the van and giving these individuals supplies, providing them gloves and hand sanitizer, who are caring for their open wounds because they're significant. They can actually take care of the wounds themselves. That is hopefully going to decrease the potential for infection, which can be severe with these skin necrosis cases that we've showed you. These individuals are provided with saline, gauze, wraps, and also an antibiotic ointment, either Neosporin, which is a triple antibiotic, or bacitracin to actually hopefully prevent these areas from being infected. Also, other harm reduction approaches include recommending avoiding injecting into the wounds, which is difficult because, like we mentioned, it does cause them some pain relief. So that's why they continue to inject in the same sites. Recommend swabbing them with alcohol before they inject, try to minimize infection. What we will let you know is that xylazine can also be sniffed, snorted, and insufflated. So there are individuals who would take the liquid, they will let it just sit out and dry out, and then they will actually snort that powder to get that tranq high with regards to that. And so there's actually mitigation strategies there with sterile water or saline for the nasal passages. Obviously, syringe exchanges are important for a needle-based model to prevent infections from reusing and sharing those needles. Provide patients with naloxone. We give those out. We give it out through our emergency room to have them take it home either themselves or to family members so that someone has it in case they should overdose again. Provide training on how to administer that. There are, with regards to patients receiving fentanyl strips, to test for that. Most of the time we tell them that it's significant in the drug supply in New Jersey, so to not be surprised if it does test positive for fentanyl. And even if it does not test positive for fentanyl, that fentanyl may be present, especially an analog that would not trigger the strip to actually test positive. Provide point-of-care testing for xylazine when we have that available. And there's also these resources here to never use alone, both in English and Spanish, and the Brave app if individuals want to gain access to that as well. So research, educate, prevent for the integrity of your work. You'll be recognized, maybe not with praise or awards, but with lives touched by your life. So thank you for all that you're doing out there in the Sacramento, California area with your organizations. Thank you for your service. We appreciate that. And the key takeaways here as well are with regards to hydroxylated metabolites of xylazine are detectable in human urine, so you can test for it if you actually save the sample and have it sent out if you don't test for xylazine, and most hospitals do not. Cases provide information on how to manage xylazine and fentanyl, more being published. We have our colleagues from Cooper Hospital in Camden, New Jersey, presenting a case as well that they're publishing to show how patients can be managed with this for their withdrawal and also the overdose component. Further studies are needed, though, with regards to combinations on how to provide data on guiding treatment options for this. And we do need studies actually on human antidotes. So like we have naloxone for opiates, tolazolene is actually used to reverse xylazine oversedation in animals. We do not have tolazolene studies in humans to reverse xylazine, but there was a study done with tolazolene to reverse Precedex, dexmedetomidine. That is also an alpha-2 agonist like xylazine, and it did work to reverse those patients who actually were trying to have a reversal agent on their dexmedetomidine. What's important there is we know that this works on an alpha-2 agonist in humans, but again, would not know for xylazine with regards to the dose, how much we'd have to give, how readily it would work, and what the time frame was, and would it be needing subsequent doses if one dose wasn't strong enough or last long enough to reverse a patient. And that's data that we do not have, and you do studies on that as well. Also, the opiate epidemic continues to evolve in our country. And unfortunately, emerging evidence shows increased prevalence in unregulated drug markets like xylazine and others. This xylazine adulterant has contributed significantly to fatal overdoses nationally. Will continue to be used as an adulterant because we showed you they can use less fentanyl. And more clinical cases like this will occur. Like I mentioned, we see this, unfortunately, a significant rate in the East Coast, and in particular where I work at the hospital. And xylazine should be considered to add to routine toxicology for detection and proper treatment. Also, harm reduction should be provided for xylazine-specific modalities of care that we talked about. And also policymakers should consider regulatory structures to mitigate these unregulated drug markets, including making xylazine potentially a C3 substance. And we all need to have further studies done to increase our knowledge and understanding of xylazine mixtures in these overdose patients and to provide data on how to treat them as best as we can. So with regards to questions, just for your own edification, what are some common illicit drugs that are currently being cut with xylazine? After seeing this presentation, you can think of what those answers were. And if you had access to the chat, we'd have you put it in there. But the answer there is all the above. They're all being cut with xylazine. With regards to what pharmacology drug class is xylazine, primarily, it is either opiate mu, GABA receptor, alpha-1 or alpha-2 receptor agonist. It is D, an alpha-2 receptor agonist. And then with regards to naloxone be administered in xylazine suspected overdose patients, the answer to that is yes. All the time to do that, just to make sure that we're reversing the opiate component if that is part of the drug overdose. And now you get to all play the clinician. What if you have a patient comes in, 38 years old, Caucasian male, longstanding polysubstance abuse. He's found unconscious in his apartment. He's sent to the emergency department from EMS. Other past medical history is not significant. When he arrives, he was down on the floor unconscious, diminished breath sounds, pinpoint pupils. He has the meiosis, bluish skin tone. Naloxone 4 milligrams intranasally was given. They also gave him naloxone 2 milligrams intramuscularly 3 times by EMS. In the emergency room, he's still unconscious. His pupils are now normal size, but his BP is still low. His heart rate is low at 55. He's febrile. He has a fever. His oxygen saturation is 89%. Breath sounds are clear. And all labs are pending. So the question is, what would you do with this patient? Should we give another dose of naloxone? Should we start the Vanco and piperacillin tazobactam for possible sepsis? Or should we actually stabilize him hemodynamically with intubation, fluid resuscitation, vasopressors to raise his blood pressure and heart rate if we need to, and check signs for necrosis and those kind of things? And the answer here is actually to provide the supportive care, because we've given significant amounts of naloxone already. He's received 10 milligrams total with regards to intranasal and intramuscular injections. His pupils are normal now. So we've probably covered the opiate component. If people want to give another dose of naloxone, that'd be fine. We don't think it would be much benefit. But the key here is because of the saturation of his oxygen level is only below 90% at 89%, he probably needs to be intubated and then treated accordingly with regards to that. So thank you for all that you do out there in Sacramento. I'm sorry we couldn't be with you personally, but we're out here on the East Coast and giving you that kind of information. And with regards to that, there in the presentation are 16 references listed here that we used. You can actually go back to this presentation, hopefully from your organizers, and look up any of these references you'd like to be able to access more information on xylazine. As I'm sure Ed and Dale have told you, if you thought this presentation was great, please put that in there with regards to your phone and take the survey. It only takes about 5 to 10 minutes. And if it was great, the presenter was William Lynch. If it wasn't, the presenter was Bugs Bunny, and that's okay. But with regards to, please fill it out, because the feedback is important. And I know that we talk at a rapid rate, but we want to make sure we get all this information for you. My contact information is there as well. If you have any questions about this, you can reach out to me, both my personal email and my Jefferson Hospital email, to hopefully provide information to you if you have specific questions even after this. And we will now turn it over to questions. So with regards to any of you out there in the audience, if you have questions in particular about the cases we presented and/or xylazine or fentanyl management, we've been more than happy to address those at this time. But again, thank you for your attention. Thank you for coming to this session of your meeting, and we hope you enjoy the rest of your meeting out there in Sacramento today. So thank you very much for having me.
If I missed this, why in particular New Jersey? Is there like an avenue they've been seeing that's coming from like Europe, or like why not also New York or surrounding states, out of curiosity?
Sure. So actually the question with regards to is xylazine being significantly seen in New Jersey is because of the fact that we have literally the Betsy Ross Bridge, the Ben Franklin Bridge, and the Walt Whitman Bridge, if you're familiar with the East Coast at all, lead from Philadelphia to Camden County, New Jersey. So it's significant with regards to the presence. And we have more xylazine in South Jersey than we do in North Jersey, just on the numbers that we've seen with regards to samples that have been submitted. This is important because of the fact that this has really exploded in the Kensington section of Philadelphia. And because of that, it's rapidly transported over to our drug supply and has also been seen significantly in Camden City in New Jersey. And then it proliferates from there. And for us, either I-95 corridor, the New Jersey Turnpike, Garden State Parkway, routes 42, 55, and 295 are significant routes that traffic this supply to other parts of the state. And so, as mentioned, we have seen xylazine in every section of the state, including all 21 counties. So that's primarily what it comes from. It is through primarily diversion, but there is some suspicion now that there may be drug cartels cutting it up front with regards to xylazine, and that could be pretty disturbing because then it could actually spread across the country quite readily if the drug cartels start to realize that they'll be able to use less fentanyl if xylazine is actually in the mixture. So that's a concern, but that's pretty much why we've seen it explode into South Jersey and New Jersey in particular, because of our influence from the Philadelphia area for our drug supply.
Bill, looks like we've got no other questions. So with that,
Okay.
thank you for your time. We'll keep the recording on hand and we'll go from there.
Thank you very much, everybody, for attending today, and enjoy the rest of your conference. And we thank you for the invitation opportunity to share this information with you. Have a great day and enjoy the rest of your conference. Take care.
Thanks, buddy.